that it's a common condition, but I think many of us have not really understood how common it is and how common it will be. These are data sets from the United States, the lower one essentially garnered from health records in California, and the upper two coming from the Mayo Clinic and the Olmsted County region around the Mayo Clinic. You'll see that in California, from health records, it was determined that about 1% of the United States population in roughly 2012, or 13, where we are now, about 1%, according to this survey, have atrial fibrillation. The figure is exactly double in Olmsted County. That's largely because any inhabitant of the Mayo Clinic gets an ECG every second day if they're not careful. Certainly the Mayo Clinic deals with them in great detail, and therefore everything is known about their medical record. But this is probably a more accurate reflection of the prevalence of the condition, 2% today. And we know that just because of the simple demographics of an aging population, this will at least double. So that's from 2 to 4% of the population by 2050. And if we make the not unreasonable assumption that as this population doubles in size, the members of the population will age with underlying cardiovascular disease, such as treated hypertension, a growing incidence of diabetes, and so on and so forth, it is likely that the upper curve will be the most realistic, which will take us to 5% of the population with atrial fibrillation. Now, in that regard, 5% of the population means a prevalence, say, in a territory that is cared for by one small to moderate-sized general hospital of, say, 250,000. It means we're talking about 5,000 patients in that territory with atrial fibrillation. And the incidence is roughly a third of the prevalence. So let's say 1,500 new patients every year for a 250,000 patient community. And if you make the divisions, then clearly that's something in the order of 5 to 6 per day, or 30 or so per week new patients. So this is a burgeoning public health risk, and we're looking at all ways that we have to try and reduce the thromboembolic risk, which on average, as you know, is about 4.5% per annum for patients untreated with atrial fibrillation. So it is a very worthwhile objective. For those of you who are not EPs, it's worthwhile reminding you that not all atrial fibrillation is the same. Not all atrial fibrillation is thrombogenic. Roughly, we can look at two ends of the spectrum of atrial fibrillation as illustrated on this slide. In the upper panels, we see a patient who has myocardial myocyte preservation, does not have any fibrotic replacement to speak of, has small atria, and this is the classic patient with idiopathic or lone or early atrial fibrillation. The lower panels show a large atrium where myocytes have largely been replaced by fibrosis. This is so-called anatomical atrial fibrillation. You could call it pathological atrial fibrillation, or highly remodeled atria. These patients are at substantial risk of stroke, whereas the patients in the top panel are not at considerable thromboembolic risk. Now, as far as public health issues are concerned, in Europe, we can summarize the burden by saying that there are 2 million strokes a year, costing some 38 billion euros. 20% of these strokes, roughly, are attributed in some way to atrial fibrillation. It says on this slide 6 million Europeans have atrial fibrillation. It's more likely to be 12 million. In the United Kingdom, simply by paying primary care doctors to discover atrial fibrillation, the prevalence went from 0.75% to 1.75% in just 3 years. So there probably are more like 12 million Europeans with atrial fibrillation, and the risk is increased for stroke by 5 times in the presence of atrial fibrillation. And as you know, AF-related stroke is more deadly, higher mortality associated with it, and more disabling, much greater morbidity associated with it. Now, not surprisingly, guidelines have been blossoming or burgeoning in relation to atrial fibrillation. This is just a selection of them, ones that have had some form of international importance, ranging from ESC to ACCF and AHA and HRS, the Canadian Cardiovascular Society, the American Stroke Association, part of the AHA, and NICE in the United Kingdom. The latest of the guidelines to be printed was the 2012 update of the 2010 ESC guidelines on atrial fibrillation. And the point of just mentioning this is to say that this was the first time that a recommendation appeared for the use of a left atrial appendage closure device. You can see it's a very limited indication. As you know, the underlying evidence base is still somewhat slim for the use of a device of this kind, but we were able to write interventional percutaneous left atrial appendage closure may be considered in patients with a high stroke risk and contraindications for long-term anticoagulation. Many of you will have a much wider perspective of where this device may be indicated, and we'll explore that further this morning, but this at least is now in the literature. It's the first guideline of its kind. And I think it's worthwhile looking at the overall plan for how we might approach thromboembolic protection in patients who have atrial fibrillation and risk. Risk is usually assessed using a scoring system. In Europe, we choose the CHADS-VASc scheme. In North America, they still use the CHADS-2 scheme with additional risk factors which make it very equivalent to the CHADS-VASc scheme. Once we've assessed thromboembolic risk, we're supposed to consider bleeding risk, and there we use the Hasbled score in Europe, and in North America, either the Hasbled score or the Atria score. At that point, we have to make a decision between what form of thromboembolic protection we would recommend. We have a choice between vitamin K antagonists, the so-called NOACs, or novel oral anticoagulant drugs, antiplatelet drugs, either aspirin alone, but preferably the combination of aspirin and clopidogrel, and finally, an opportunity to consider for patients who have at least a CHADS-VASc score of 2, but cannot take anticoagulants for some reason. We have the choice of left atrial appendage occlusion, which is in the bottom right-hand side of this particular chart.